Thank you, everyone, and thank you for having me. So I was going to discuss a little bit of my... Oh, sorry, I've gone backwards. Work with me. So I have a lot of roles. So from me, I'm always really interested in moving things definitely towards clinical. So I am actually a doctor, medical doctor, and I work in medical microbiology. I have also done infectious diseases. I am a researcher at my core. So I originally started out doing a PhD in microbiology. I was a full researcher and then moved into doing medicine. And then I like to call myself a researcher who became a medic who was still a researcher. So I understand the lab part and I'm still really passionate about that part of research. I'm currently an honorary lecturer at the university. I'm finishing off my training to become a consultant within the next 10 months. And I'm also still the clinical lead at the Becky Mayer Centre for Phage Research, which is still the only centre in the UK. So what I'm going to whistle-stop talk you through is, because when we say phages, does everyone know what that means? Someone over there does? Well, what does that mean? And what does phage therapy mean? So I'm going to give you a quick tour of that and then talk about what I do with moving my research between thinking clinically from something that is affecting patients that I deal with in real time and wanting to try and solve that problem. So, what are phages? Okay, so if we're going down the route of thinking that everything has evolved in time and we never find anything new, we can just use nature to our best advantage. This is what phage therapy is. So bacteria, like ourselves, they get coughs, colds, they have viruses too. And they have viruses that specifically infect bacteria. Now, the thing that we are trying to take advantage of is the fact that during this infection process, they will kill the bacterial cell. They will just burst out of it and kill the cell. And that's what we want to take advantage of. So you could think of it as coming in and as a new science that's looking at itself as a good virus. So we've learned that we need our bacteria. We know about good gut health. We now need to start thinking, well, actually, do these viruses work? And there was research looking into that. Are they part of what's making up your natural microbiota and actually keeping you healthy? Is there a reason why you're healthier than someone else? And so we're looking at that. Now, phage therapy is just using this in a clinical context to treat a bacterial infection. And that's the route that I'm going down. So phage therapy, again, not new. Phages were actually found before antibiotics were used before antibiotics and are in certain places in the world are used just as much as antibiotics are used, phages are used to treat. So we're talking about places like Georgia, Poland, Russia. Just as much as you can buy antibiotics, you can buy phages, you can go to a pharmacy, you can get these things. So it's not something new, it's just something repurposed in a way to try and fight something that we all in this room are very aware of. So where my research comes in, and I'm sure a lot of us all know about the escape organisms, the World Health Organization, what our priorities are. So my research priorities come in the fact that I'm interested in ESBL producing organisms that are E. coli, Klebsiella, in urinary tract infections, and they come in this big group, which is the critical group at the top, which is now known as Enterobacterales, third generation cephalosporin resistant, which is just a posh way of saying what I just said. So that's where I am. So, phage therapy, again, being used in UTIs, we have a hole in our research, and this is where I'm trying to plug this hole in this time. So you can see there are case studies. It's lovely to have case studies. That is a one-shot. I will tell you amazingly about all the things that I can do clinically when it works out. I will never report anything where it doesn't work out. So you have publication bias, but you do have papers that have shown that people have treated urinary tract infections with phage therapy. We are starting to move, and it's moving quite rapidly within the last 2 years, and we have started to have a lot more clinical trials that are moving towards saying, I want to treat this infection, mainly looking at bone infections, urinary tract infections, things where we've got a lot of resistance, things where we've got difficult to treat infections. This is where phages are going to come in. So we have started to move in this direction, but nothing is finished. So I expect in the next 5 years we'll start to see a lot more and a lot more movement in this space. So, as I said, that's just a whistle-stop tour to get the base of the audience up. So what I'm looking at is a product that I have designed during my research over the last 6 years, and it's called LCPR1, which was very imaginatively We used to be called the Leicester Centre for Phage Research until somebody donated a lot of money, and then it's now called the Becky Mayer Centre for Phage Research. So that's all that stands for, and it was our first product, and it was specifically for UTIs. So I'm just going to do a whistle-stop tour to give you a flavour of the different research, and I am very welcome for anyone to ask me in more detail of the main studies that we've done to try and prove that this would be clinically valid research. So, preclinical development. So back when I was still doing my academic clinical fellowship, I went through a method just to design a way for us to say, actually, is this phage better than that phage? And if I use this group of phages, is that better than that group of phages? Because before we just looked, there were some holes on a plate, but actually started to make it a little bit more scientific so that you can use a numerical system where you can say, okay, that one's 0.4 and that's 0.5. 1 being the best, 0 being it doesn't work at all. Let's start using these methodologies so that we can start to discuss things in a scientific way so that it's also lab translatable. Going through all of that, the product was designed to then have 3 E. coli phages and 6 Klebsiella phages. And I think as we've had other talks, we've talked about them being some of the top ones that are called bloodstream infections. These are the top 2 organisms, so you can looking at about 85% of UTIs are actually caused by these 2 organisms. And these are the ones that acquire resistance easy enough. And these are the ones that cause problems because then there's no oral options in the community. People, every time they have a UTI, have to come to hospital. That's bedtime, that's bed space. That is things that we don't want. And for the patient, they don't want to have resistant infections where they're difficult to treat, where they have to stay in for 10 days. These are things that I think about from my point of view. So, study 2. Okay, so I've made something, and as we all say, it works in the lab. Congratulations. Let's move forward. So, this was my PhD student, Riska, who's due to have her viva in the next 3 weeks. We went and did a biological model. So, we did a mouse model of a UTI, which, as we say, so this paper is already preprint. We have already submitted it. Important thing is that, as we always say, this data took years to make this mouse model where we could consistently get back from the urine of a mouse Klebsiella, and we make the model last for 7 days. So that was the first part that we needed to get down. The next part was then showing, could we add some phages in there and make a difference? So this is what this data shows, is if on day 0 I infect my mouse with Klebsiella in a bladder, and you're getting it back from the urine. So we did an actual amazing thing, which we trained the mice with a chocolate-like treat, and we got them to urinate on demand so that we could get urine from these mice over 7 days, because imagine you're just trying to catch them on the fly. So they were very well trained. And what we did, so by the time we've got a fully established infection, day 2, we either did a complete sham, just to prove that adding some liquid into your urethra doesn't actually cause you to get rid of the infection, so we just use PBS. And then either you had the phages in PBS on day 2. And you can see from this data, and I apologise, I don't think this pointer is going to work, but I hope you'll work with me. As you're moving along, you'll start to see that in blue, from day 2, you're getting a significant reduction to where on day 6 and 7, you can no longer find any bacteria in the urine from those mice. And you can see that with our control group, you can consistently get bacteria received from that. We have the similar data, I did say whistle-stop tour, so you can see the same thing in the bladder, you can see the same thing in the kidney, you can't get it from the kidney on day 2 and 7. So this was really interesting data. We were surprised that we got away with just giving 1 dose on day 2. We thought we'd have to play around with it a little bit more. We have done more data where we've done a longer model, where we've gone on for 14 days just to show that that infection doesn't come back. Because clinically, I don't want something that will treat it until day 7, but then on day 10, my infection reoccurs. So I'm thinking of it more clinically. But this is the data that we've got to work with so far. And again, I can show that what would be important for us clinically is, okay, so I've used the phages, but if it does a massive damage to my bladder and my bladder wall, I'm also not interested. So again, we did prove that with untreated, we had less damage with the phage-treated ones compared to the ones that had completely no treatment at all. So we were showing that there was no immunodamage, there was no histopathological damage that was being caused by the phages themselves, which was a concern. We did also look at cytokines, but I had limited time for this talk. Okay, so Study 3, so my other PhD student who finished last year, was then looking at what would you happen if you use phages against standard of care. Again, an important question to have, because there is no way in hell that I'm going to risk my patient without standard of care and just go, oh, do you know what? Don't take antibiotics, just take phages, see how your sepsis goes. It's not going to happen, it's not realistic. So you're going to have to use this alongside antibiotics, but if that causes more chaos, if that causes it to be worse, again, that is not something that's clinically relevant. So we went down the route of going, okay, let's try and look and see what happens when we use standard antibiotics that we would use clinically alongside phages, what happens. This was a lot of data. Again, this is available as a preprint. This was only last week, I think. We only put this out. Took a lot of data. So what we were doing was we were using Thermo Fisher. I have to put it up there because they donated the plates for free. And so we got to use their system. And this is basically based on an MIC system. You've got all these antibiotics that are in there that are normally used to treat a UTI. And what we were using as our marker was to see whether the MIC stayed the same, whether the MIC increased, whether the MIC decreased. And that's what we were looking at when we were adding the phages to these plates. Now, this is, again, a great image that she designed from her talk, and you can see that we did thousands of combinations. So we had overall 13,485 different combinations. This was a lot of data to trawl. This was a lot of data to try and pull out, and I do invite you to read it. So we were looking at different types of antibiotics. So we're talking about what difference happens when you use a fluoroquinolone, which is a very common one to use between whether, like we've talked previously, beta-lactams are our workhorses. So what are you doing with your workhorses? And seeing what those interactions were. Did they make things better? Did they make things worse? Did they just do nothing in particular? Nothing is also a great thing. I don't want it to, if it had no effect. But you can see that most of the time, it had no significant effect when you're looking at the left-hand side. So 7,551 of them, nothing really happened for E. coli, but there were some significant ones. But the most significant things are always additive. There is some agonistic ones, and you need to look into that, and we'll look into it more, but 1.3%. I feel that again, is showing that even though that can happen, it doesn't normally happen. And again, on the Klebsiella side, again, the antigonist, don't know why that word's not coming to me, is 0.8%, whereas the majority of those positive significant effects were an additive effect. But I'm just saying, we did this on a scale. This had previously been done. People used a few strains, just did things, but nobody's done anything on this scale where there's this many different combinations of many different classes of antibiotics, things that are clinically relevant in a large number of E. coli and Klebsiella strains that specifically come from UTI. So this is new work. This is something new, and it's good to see so that we know we can be more confident clinically about what we want to do. We do have some complementary data. Again, as I said, that is another paper that we're currently working on where we had used antibiotics alongside the phages in our previous mouse model to show those interactions as well. So that will be coming from us. And then the last study I just wanted to talk about was study 4. And again, I always stress what is clinically relevant. Okay, so biofilms are really important as part of UTIs, and as a basic concept, a biofilm is somewhere where a bacteria can hide away from antibiotics, hide away from treatment, hide away from being washed away by your urine. So what are you going to do about that? Can we do something about that? If that's an important part of its pathogenesis, can we do something to help with that? So we were looking at biofilm disruption, and that was a key part. Now, the thing that was from Karen's work again. This paper is in the process of being written. So what you need to understand is this is different biofilm work. This is really nice, clinically proven ones, not ones that we make in the lab, and I'm sure many of you have done it, where you make it over 24 hours and you do a little biofilm, do it on a 96-well plate. These were biofilms from catheters from actual patients. So we went to clinic, 20 patients. These people had had catheters in for 3 to 6 weeks. So these biofilms are solid. They have been made through infection, and we were proving that a lot of the times we were only collecting them if those patients reported an infection on changing of their catheter when they were going to clinic. So these are really good, sturdy, week-long built biofilms that we were really trying to go in for and prove that we could do something different. So what we've got here is an artificial bladder, as you like to call it, and we had artificial urine running through. What we would do is we'd cut a catheter from a patient in half. Half was treated with phage therapy, half was not. And then at the end of it, we would have a look and see what the outcome was. And what we do is we do this, so still at 37 degrees, the artificial urine was running through as a physiological, it's okay. And I've just got this, so this is my last slide, don't worry. And then, so what you can see at the top is, you can see the really thick biofilms at the top there. And then at the bottom, what you're seeing is then, when you put your phages through, that is really cleaning through that biofilm. So you're reducing that biodensity and you're really moving through. So that was something really nice in our data. And then the last thing I was just going to say is, even if we prove that that biofilm and that infection was not caused by E. coli and Klebsiella, because of the phages that we had in there, we were still breaking down that biofilm. And I'm out of time. And I did say it was a whistle-stop tour. And then that's just my summary. And I want to show, I have plans for a clinical trial and just show everyone and say thank you.